and we'll get started. And thanks everyone so much for spending your time joining us for this. I hope you find it useful. Okay, can everyone see? Nice, okay. So I'm going to be talking about the 1-minute preceptor model. I have titled this Micro Skills for Maximum Efficiency because I think this kind of best captures what's going on here with this model. So our objectives are pretty straightforward, and I think you'll all catch on to this pretty quickly when I go through them. Name the 5 micro skills of the 1-minute preceptor, explain the advantages or really the roles or purpose for why we're doing these micro skills, and then we will get to apply this. And if anyone has used this model before, I would love to hear you chime in. We'll have kind of a case, we'll see how it goes, and hopefully get some open discussion about it. So what is the 1-minute preceptor? This is a technique that originated, really, it was first heard of in 1992 by Naher and colleagues. They published this 5-step micro skills model of clinical teaching. And these authors, they reviewed the evidence for what was going to be the most successful teaching behaviors. This was done for family practice physician preceptors. So taking that in mind, they ranked those, what they thought were the best qualities, into the most effective, versatile, what they thought were the most important behaviors, and then they boiled that all down to 5 micro skills. Later on, this technique was named the 1-minute preceptor, which I'm going to abbreviate OMP throughout. But they called it that because of its ability to really help maximize both patient care and teaching time. So that's why it's taken on that term. And the idea is really simple. In busy practice, we really have to accomplish 2 things. We have to accomplish patient care for the patients, but at the same time, we're also expected to teach and teach effectively. So where did they get this 1-minute thing from? So assuming your encounter is 10 minutes where you have this time with the student, and they're presenting to you, and that learner is going to spend maybe 6 minutes of the time presenting the patient to the preceptor. And then maybe the preceptor questions the learner for about 3 minutes to get the full story, find out what's missing, and then make sense of what's going on and what they need to actually complete the patient care. And by then, really only 1 minute of the 10 minutes is left to address the learner's teaching need. So I don't think this is necessarily meant to be taken literally, that all of this teaching is going to happen in 1 minute. It's just meant to evoke the way that it maximizes your scarce teaching time. So this is really supposed to be an alternative to a traditional style where the 1-minute trained preceptor will concentrate on both the patient care and the student learning by applying what are these 5 micro skills, which the micro skills are basically tiny little teaching strategies or steps. They're designed to sort of prompt students along the way to explain their thinking process using more leading questions, open-ended questions, and then they allow the preceptor to address that and give the needed learning support. In contrast with the older style, which is just the student or learner presents at you, does not elicit, you don't elicit any thinking process at all. There's not really reasoning. It's just, here's the stuff. And then the preceptor takes what they need and finishes the patient care. So we want to be able to integrate both of those efficiently. And so Naher and colleagues, of course, when this first came out, they wrote the original paper for family practice physicians, and that was the setting. But since then, it's really been adapted widely throughout. So there's lots of nursing preceptors, nurse practitioners, all kinds of different settings. And of course, pharmacy has adopted this as well. So you can probably already notice some advantages here. One of the advantages of the model is to actually steer preceptors away from the pitfall of just giving mini lectures to the learner. And some of the things when reading about teaching and researching this is that a lot of the newer teachers tend to just kind of say, oh, like the students talking about this, the learner mentioned this, now let me give you a mini lecture on that. And then they just kind of teach back at them. So this model will address that problem of only kind of focusing on patient care, and then let me kind of spit out a mini lecture if I have time. And then the student is left hanging. And then they're kind of like, well, what do I do with this mini lecture? So newer preceptors tend to do that, apparently. With the strategy, again, you're utilizing the entire encounter, so it's really just efficient through and through to get the decision-making process. It's also designed to work well for part-time faculty who maybe don't have the advantage of continuous or longitudinal contact with the student. So maybe if you're like team teaching, or you have multiple preceptors, and you can really use this in a single encounter versus trying to figure out where do we leave off on teaching this topic. All of it can be packaged in one lesson for that single patient encounter, even if it's just a few minutes that you have. This is best suited for times when the learner is presenting the patient to you. But it can be used in a wide variety of like patient acuity and settings and phases of care. I actually personally think it's useful for evolving cases in the emergency department where there's not as much time to pause for that didactic teaching part and pick things through, but there's an opportunity to think through what's happening as the case unfolds. So there's a lot of leading questions that can come out for that. Even though it was designed more of like a clinic setting, you can really apply it to different cases. It can also be taught pretty quickly. A lot of the studies doing this use just a 1 to 2 hour teaching session like the one we're doing now to teach this. So it's really accessible to people. And, instead of physicians making a diagnosis, I like to think of this as the preceptor focusing on when the student or learner presents their patient case to you, the preceptor is sort of taking that and diagnosing the learning, and then in the remaining micro skills, there's certain steps that you'll see where you're actually kind of treating the learning too. So it's like a diagnosis treatment, but for teaching. So I think that's really interesting to see it from that point of view. So all of this model is broken down, as I mentioned, into 5 micro skills. So the first one is to get a commitment where you get the learner to make up their own decision on what's going on. And then you probe for supporting evidence. So find out how the learner arrived at that commitment once they make the commitment. Teach general rules based on what they saw. The preceptor can offer simple but really targeted, we want something specific, pearl for the future. Reinforce what was done right. So provide some specific examples of good things. And then doing that, corrective, modifying feedback as the last step. So these are sort of intentionally ordered this way from the traditional model, but you don't necessarily have to do them all or do them all in order. Even just 1 or 2, I think they stand pretty well on their own and they're just good to know. So keep that in mind. It doesn't always have to be in this structure, even though the idea was that they were designed to maximize by following this series. But again, we like to be flexible sometimes and we need to be. So again, you can see those steps 1 and 2 kind of diagnosing. This is the part where the learner tells you information and you're leading questions, but really giving them the floor. And then these, teach the general rule, reinforce correct mistakes. That's the treatment of the learning. So I'm going to go over these steps in more detail now, just to give you some examples of do's and don'ts and what this actually looks like. So step 1, get a commitment. So this is where you want to listen for the learner when they've given their patient presentation to you and then they stop presenting, or they look to you like, what's next? And then you're really asking them to think and continue thinking. So this is where they stop at sort of an incomplete point. And perhaps maybe they've presented some facts, they've done their data collection step, and they're coming to you. And they want some guidance. You can tell it's like, okay, I'm gonna jump in and solve this for them. But instead of that, you're going to ask your learner to get a commitment. And this is what they think is going on. What is the problem that the patient is having? So these are the what questions. So make sure that you're using that learner's pause to actually encourage them to move forward with what they started. And this is probably going to require them to step out of their comfort zone a little bit. Maybe they'll be hesitant, but you really want to resist the urge to overtake them and jump in and finish the case. Especially when we're really busy, we want to do that sometimes, but this can be overwhelming to them. Sometimes you have a lot of questions, like maybe there's a lot of gaps in the presentation. It's like, okay, what about this? What about that? You didn't get the vital signs, but you want to resist the urge to have all these really specific questions, because in the end, that shows you more about the preceptor's process than actually giving you information about the learner's process. So a few basic questions is fine, just to clarify, but really you still want to give the learner the floor and ask them to make a commitment there. We're not spoon feeding them anything yet. So the goal is to really get clues about the learner's thinking process, their ability to make an assessment. And this shows that they can actually process their own knowledge, reach for things in their foundation of knowledge. They can synthesize the case facts to actually get something to go with. And a good kind of byproduct of that is that the learner feels responsible for the patient. Now they're engaged, it's more active and personal. It's going to facilitate independent thinking by the learner. And a lot of adult learners really prefer that. And it also shows them respect to, like, okay, I want to hear what you think first. And along the way, of course, you start to learn about what the learner knows and what they're thinking. So that's step number one. Some examples of this, like what are we actually going to say? Again, those what questions. So what do you think is going on? It can be really simple. Just, what do you think's happening? Or you could ask, what additional information or workup or monitoring would you want to know? Like, what further questions do you have? So like, what medication needs do you anticipate now? What are the next steps? What's going to happen next, and what do you prioritize? So asking them to sort of prioritize or envision how it's going to go. And then what do you do when they respond? How do you interpret their response? Maybe they can't decide at all and they're kind of hesitant, which is a clue to you that they may not have really processed the data. And they might be worried about being wrong, or they're just not at a stage where they're independent yet. And it's okay if the learner is struggling in their response. Maybe you can just be reassuring and be like, okay, make an educated guess if you have to, that's fine. We want to encourage them to try and create a safe space where they can do that and recognize that you're there to help them learn. So just narrate your thinking process. If they say something correct, that's great. If you agree with them and you can reinforce the positive skill and keep moving. If you need to modify it, if it's not correct, then you have a teaching moment. And you've probably had a greater impact on the learner because they're going to remember that and they're going to remember their mistake going forward. That's pretty powerful. Next step is probe for evidence. So what's the basis for the commitment that they made? The second micro skill is basically moving forward based on that commitment that the learner made. These are the why questions. So here you listen for when the learner makes their commitment, and then again, looks to you for confirmation. Okay, I assess it as this problem. And they're kind of like, was that right? Was that the answer you were looking for? Keep going. So make sure that you're responding with leading questions to that. And even if it's not correct, you want to still continue to ask them why. Why did you make that commitment? Why did you decide that that was the biggest problem the patient is happening right now? Why did you make that medication recommendation? Why did you prioritize that first? So we don't want to be judgmental at all. We don't want to come off as grilling the learner. It's just to, comfortably have them think out loud. The goal is to find out what the resident knows or doesn't know to help you target your teaching, right? It encourages clinical reasoning. So this is a really, really great advantage, is that you get to see, was this a lucky guess and they're just kind of reaching for something, or was this based on some evidence and they're, a solid foundation of knowledge? So in healthcare, this is really important. We don't want to have people making lucky guesses. We want them to, have a reason why they chose one intervention over the other intervention. So this step is designed to give you that. An example of what that looks like in terms of the why questions. To recap, let's say the resident made their commitment and told you what they think about the patient, and now it's your time to follow up with the why and how questions. So you could ask, even if they've given you some assessment of problems, or maybe they've given you a choice of a priority for something, you can ask, what factors led you to list the problems and put them in that order. Or if they're committing to a therapeutic plan with a medication recommendation, why did you decide on the particular medication changes? Why did you want to change that medication first? If it's a dosing change, how did you arrive at the dose? You can also ask what choices were considered but not included, and why they eliminated a certain choice or eliminated a certain decision. So kind of ruling in and ruling out certain things. So lots you can do here. And then after they give their rationale, now you are armed as the teacher with really great information about their knowledge base, their reasoning, and their understanding of the patient case as well. So now you also know what's going on with the patient, and proceed to the next steps. The third step is now where the teacher is more synthesizing the information. So this is teaching general rules, and now you're kind of taking action here. Sometimes this step I've seen swapped and placed fifth, last. So again, you can do it however you like. In the original publications, it was placed third, so I kept it third. But here, the resident gave you their commitment, they gave you the reason behind it, and now it's your time to come in and address the need. Again, if they gave a correct answer and you agree with that, and maybe you've been, teaching them really successfully and they've totally got it, and you don't think there's anything to learn, you don't have to waste anyone's time. You could skip this step and keep moving, right? Because you're busy, you have more patients that you have to take care of. So, you don't have to go into every detail with every patient. Again, resist doing all those mini didactic lectures. If there's no other pearls to learn from it, continue on. And the reason this is about general rules rather than specific scenarios is that you don't want to give like a preceptor's personal opinion that only really pertains to a detailed situation. You want the learner to be able to apply these things to new cases and generalize really, basic foundational things, and see that first, and then go and apply it to different scenarios. So that's why you want to keep it simple, keep it general, don't bog them down with a lot of information. So just a few examples of this. Again, short and sweet. When there's bacteriuria without clinical symptoms of a urinary tract infection, this is asymptomatic bacteriuria, and it doesn't require treatment with antibiotics unless the patient is pregnant or will undergo urinary tract surgery. So in the emergency department, we evaluate a lot of urine culture results. So this may be a good teaching pearl. And even preceptors are still learning, and healthcare is a really multidisciplinary effort. There's all kinds of things that we may come across that we still, haven't heard of. So sometimes neither you or the resident know how to answer the case. So what general rule do I teach? Well, in this scenario, you can teach learner who to go to or where to go. So you can always teach about how to utilize resources to access them, which is why in the original Nahara paper, they have this example that I really like, where you could say, I haven't encountered this condition before. The best references are blank and blank in the hospital. The person to check with would be blank, our specialist is blank. So really linking them in and encouraging a multidisciplinary feel for them. So you can also offer mnemonics to help them remember things, really giving the big picture here with the teach general rules. So fourth step, this is the probably more enjoyable one because you get to tell the learner what they did right. So every good thing, every really positive behavior deserves to be pointed out and reinforced because maybe the learner didn't realize that that was so great and they don't know to do it again. So this will help them keep it up for future patients. And it doesn't have to be like, you saved the patient's life. It could be maybe something that was beneficial to the practice. It helped a colleague. It was good for the workflow or the clinic. So, think broadly on this as to, what good things you can find to reinforce. But when you're giving the feedback, you want to make sure to be specific about the actual behavior or skill or thing that they did so that they know exactly what to repeat and why. So as we all kind of have a feeling for, even though it's really easy to say, great job, that was awesome, excellent. And it works well when we don't have a lot of time to just say good job, but that's really vague. It's not a good teaching strategy because it doesn't explain what was good and why. So make sure you're as specific as possible. Also try to include what the positive result was of their action. Why was it good? What is the downstream effect? So this, in the end, the positive byproduct of this is to really, create a great learning climate where they know that they're happy, you're happy with things, and this is really constructive. So use this to really support your learning climate. And there are many, many examples in our practice. It could be just as simple as vancomycin dosing. So the vancomycin dose adjustment was well supported by the patient's past vancomycin dose requirements, current clinical status, creatinine trend from baseline, trough timing, and what you did will ensure that the patient has therapeutic levels without toxicity. So in this example, the preceptor is listing specific factors that were taken into account. That was done well, and the positive aspect of the patient now will have therapeutic levels without toxicity and why that's good. The last one is a little bit harder for some people. This is where you offer the constructive feedback. Once you've heard their rationale, you've heard their commitment, you've done the diagnostic. Now you need to treat something in the learner or the learner's technique, or maybe something you didn't teach well the first time. So this is the modifying feedback. And this is really important. And kind of similar to the fourth step, where you need to be as specific as possible to the situation. Try to suggest an alternative if you can, so that maybe they realize, okay, this didn't work out well. What should we do instead? And you also really remember, I know we all do this, you need to be sensitive to your surroundings. So, not every time is the appropriate time to give the modifying feedback. It is true that, sooner is usually better, but in some cases you might need to wait until the emergency or the patient encounter is concluded and you have more of a private space that's relaxed. Another really good tip for kind of breaking this news is to have the learner do it themselves. And I know a lot of us already do this where we kind of say, well, what do you think could have been better? And maybe they already know, which makes it really easier to start that conversation. So this is not a place to make personal remarks or be judgmental at all. Remember, we're still keeping a positive learning climate. We're still creating a safe space where they can, they can express their disadvantages and their struggles and everything that they need to work on still. So you're still on their team. You're just helping them out. So this is where we don't want to be personal at all. We want to make sure that we're specific again. You can't just say the patient encounter didn't go well, keep studying. Again, this is vague and it doesn't help them grow and it probably just discourages them. But at the same time, we have to make sure the errors don't go unchecked and that learning can happen from them. And then I would say the byproduct for this that's helpful is to just keep a balance of both, positive and negative or constructive. We really have to have both. We can't, all have it be great, sunshine and rainbows all the time. They have to learn and take things away. So as far as examples for this, maybe you can say in your presentation, you discussed what you thought were the main problems, but you didn't include the patient's pertinent past medical history and medications, and it makes it harder for us to form a proper assessment of what's going on with the patient without this information. So in the future, remember to include that relevant piece of the history. You want to frame things as, maybe suboptimal. You don't want to say that was really bad because a lot of our learners, I think, are already pretty, sensitive to that and they want to do well and they want to succeed. So you really don't need to say much. You want to tell them what to remember for next time. And then again, be specific. I wanted to see the past medications that were relevant. And you could say, well, here's where to go to find that information for next time. Very important step that unfortunately takes practice sometimes. So I want to go into a little bit of just evidence supporting this. Now that we've talked about all 5 of the micro skills, this model has been studied a little bit. I think that the evidence behind it is still an area for growth. I think the studies are kind of mixed. It's generally positive, and I don't think we have much to lose from applying it. Here on the slide, I have a systematic review that was done pretty recently, and they were just kind of going through the evidence that supports the technique. There were 12 studies that they had found. The majority of them, I would say, are still in the medicine realm for physicians. There was only one related to pharmacy, unfortunately, and then there were 2 others that had to do with dentistry and anatomy, which really shows you the extent of application of this teaching technique. They're mostly observational. I think the quality is pretty meh, moderate if you really were to assess it. The samples they used were convenient samples in a lot of the studies. They really tested out preceptor beliefs, learner beliefs. The tools may not have been validated. The outcomes were inconsistent. So noting the limitations, I still think that a lot of the outcomes of these studies were very positive, positive perceptions about it. People feeling like it boosted feedback a lot. I still think there's a lot of room to grow for pharmacy, for actual evidence and applying this. So just to kind of summarize on the the broader view of what some of these studies found. One looking at medical students in their third and fourth year found that they actually preferred the method to traditional teaching models. Students have found in studies that they had really positive beliefs toward the model, um, and feeling like there was actual improvement in the teaching quality when the 1 minute preceptor was utilized. And preceptors themselves, when they were giving it, also showed evidence of having positive beliefs and feelings, feeling like the learning encounter was more successful when they applied it. It was also felt that there is an increase in teaching time, or that the teachers were spending more time and they were listening better to the learners. There was also a signal for improved feedback, more than a lot of the other kind of microskill type aspects of the teaching. In studies where the model was implemented, feedback to medical students increased. In one study, they said it significantly doubled, actually. And then residents had rated performance of feedback as most improved. So probably much better feedback. And then another signal for maybe improved reasoning and diagnosis of the patient that was made were better discussions of the reasoning and diagnosis when the preceptor and learner were thinking about the patient. Also increased utilization of just the teaching points in general. So you can see a lot of these outcomes are kind of across the board, but they're pretty favorable. It seems like people really like this technique. I do think there's a lot more needed sort of objectively in terms of data for the pharmacy world. I do want to highlight one. It's kind of a quasi-experimental study, really a pilot study, where this was applied in the pharmacy realm. So this is how pharmacist preceptors foster students' therapeutic reasoning using the 1 minute preceptor method. What they sought to do was compare whether preceptors trained in the 1 minute preceptor compared to those trained in without the 1 minute preceptor. Number one, utilize those methods at all in their teaching, and then whether the students actually demonstrated more frequent expression of the therapeutic process, or thinking through or talking through what they thought was going on, seeing more of that reasoning. Very small group. They basically had 4 preceptors, and they were all clinic-based, ambulatory care setting, who actually attended the 1 minute preceptor training, kind of like this one. And then they had 3 that didn't, and they just continued. And then it took them like a few years to get enough students who were doing, agreeing to being recorded. And they recorded the students in their ambulatory care setting without patient identifiers or without, breaking HIPAA. And they recorded them, and they actually went and transcribed and then coded all those things to try and see if they were really meeting those outcomes of, the trained preceptors were following the steps, and their students, when they presented, were actually reasoning through things better. What I thought is interesting is that, yes, the preceptors that were trained did more frequently follow the steps. I think they got like 40 or something recordings. So again, our numbers are pretty small here. But interestingly, when it came down to articulating the assessments and actually initiating discussions of reasoning and talking about the whys, it seemed that the non-trained preceptor group and their students actually did that more, did that better. So I don't know if this is just the methods, or maybe it wasn't really necessarily applied in the right way, or this is all just because preceptors and students are doing this naturally on their own. Unclear, but I think there's some room for this. I personally have used this technique, maybe not all the way through in bits and pieces, and I found it very helpful, even if it's just one micro skill. So I would say my beliefs are positive about it. There are some disadvantages, which you might be kind of thinking about in the background, like, would this apply to my practice? It might not be a good fit if your service doesn't have a lot of opportunities to present the patient. Maybe you don't function that way, where the learner is. I think most of the time we find a way, but if that's not a primary aspect of your structure and you don't have time, it might not be the best to rely on this strategy so much. I also think sometimes it can overgeneralize or oversimplify the teaching, forcing things into those micro skills. Again, I think we really need some flexibility here. We don't always have time for everything. And this is really assuming that the learner has already come to you with all their data collection done and they're ready to present the patient. So it doesn't address that. If they have things to work on with data collection still, then we may be kind of past that point and you need to use some other strategies. I also don't think it works well if you're in the moment at the bedside and something really emergent is going on. So I've seen that a lot in the emergency department. We're like, you know what, we can't, we can't teach a general rule right now. We have to wait until things, calm down, and I can't give you all the modifying feedback I need to right in this moment. We're going to take care of the patient first. It also doesn't address some of the more soft skills or feelings about the learner that the learner has or evokes, and maybe there's something that they're remembering about the patient, or a personal connection, or a past class or experience where they've done it this way or that way. Sometimes those more feelings or soft skills, or maybe it's because they're overwhelmed and we didn't give them their meal break, things like that. We're not going to be able to address those in this model, obviously. And again, this is not something that has to be done on every single patient every single time. That will not give you maximum efficiency. That will give you minimum efficiency. This is really just not to overwhelm the learner, but give them a few good pearls and points and takeaways from a single encounter. So you can address both, you can find out the reasoning, you can do the diagnostics, and then you can teach off of that and take care of the patient at the same time. So again, just another review, run through the steps. So we talked about getting a commitment, probing for supporting evidence, teaching the general rules and reinforcing what was done right, and then finally also correcting mistakes of the micro skills. So I'm going to pause here before we get into this case. Actually, does anyone have any questions or thoughts about this? All right, I'm gonna go ahead and we're gonna try to do this, just a practice example. What I'm gonna do is have people probably either chime in or write their comments in the chat, just to really get your brains working on the thoughts of how would you apply this. I think it's pretty intuitive. I'll be the student, for example. Say a student is has done the data collection, you're a situation where they're presenting to you and you're the preceptor, and maybe it's a patient that came in earlier. The student goes, I'm presenting to you a 67-year-old male with diabetes on insulin, COPD, CAD history. They have AFib, they're on apixaban, they're on metoprolol, and now they're coming in with this new onset tonic-clonic seizure. The patient got 4 milligrams of lorazepam IV. That didn't stop the seizure. And then I pause and I look to you to tell me what on earth to do. What happens next? Don't worry too much about the details of the case or the clinical. Just kind of think how you would approach this if you were using the 1 minute preceptor model. I'm gonna try to see if there's anyone who wants to share in the chat. Is there a chat? Here we go. What additional information do you need? Awesome. So you're asking the what question, which I think there's a lot of, if you really get into this, there's a lot of information that I would want to know. But this is a great example because you're not necessarily asking them, well, I wish you would have told me, you know, what is the patient protecting their airway or not? But you're keeping it open. Any other thoughts on how you would get a commitment? How's the patient right now? What are potential causes of the seizure? And what can we treat? Right. What would you like to give next? What comes next? Perfect. All of you are getting this really well. So I think you can ask that. What do you think is going on with the patient? You know, that really basic question. What additional information do we need? How do we prioritize this? So what do we do first? I see coming in. You could ask, you know, what medications would you give next? So I think you're all getting it. And, you know, another question I would ask is, do you think it matters if we apply the 1 minute preceptor while this is actively going on? Or would you, like, does the timing matter on when we address this? Like perhaps this patient is, you know, in your, you know, in the hallway right now and the student is coming to you with this. What would you do? Feel free to type in the chat if you have an opinion about that. Let's go see the patient. Yes. So I would probably, I like that, want to go to the bedside, stabilize the patient first. So again, going back to this, where is it right to apply this? You may not always feel like this is the right time to go into all the steps, especially at the bedside, I think is one of the limitations. Yes, during a debrief, absolutely. One of the limitations to this, you know, what if we have to give modifying feedback? What if we have to treat the patient right now? So this is much better applied afterward when you're debriefing, I think, when there's compared to when there's an active emergency or you sense that there's an active emergency going on. So just to keep that in mind. But going back to the, you know, the question, you know, you notice that the learner kind of stopped at a really incomplete point. Yes, it would be challenging to teach in the moment. It's probably better to manage the patient and review it later. But you're also seeing like you know, the learner left out a lot of details. And we want to kind of resist the urge to grill them about all of the things that we want to know right now. But also, like, assuming we're doing this in a debrief setting where we have time, make sure to create that sort of, you know, maybe it was stressful in the moment while they were seizing, but now let's create that non-judgmental environment. Go ahead, tell me what do you think happened? So great, I see a lot of good comments. I'm gonna go ahead and give you some hypotheticals and say, you know, what if the student came to you and said, okay, here's my commitment. What I think is going on is the patient is in status epilepticus. I think the patient sees because they're bleeding from an ICH from the apixaban. And I want to prioritize the reversal agent. And I want to know, you know, the labs. And here's the medication I want, it's valproic acid. So just going with that, and then taking that into the next part, how would you probe for supporting evidence when your student says any of those things. What labs are consistent with ICH? Any other thoughts? Remember, they've told you what makes this status epilepticus. So remember, we also want to be asking those, this is where we get to see, where did their assessment come from? I see a lot of what questions, which I think could also be why questions as well. Like, why are you saying it's status epilepticus? Or, why did you mention labs? Why? Why did you select valproic acid? Good. What supports the diagnosis? What else could be happening? Good. So we're still leading questions. We didn't jump in at all to necessarily grill them. Of course, we wouldn't ask every single question everyone put in the chat. But these are all really, really important, and you're kind of getting the idea of keeping on going, not jumping in. Why is that happening? What additional information do you want here? What about this presentation is consistent with status epilepticus? So I'm gonna just go forward with the hypotheticals. I think you're all doing really awesome, making awesome comments in terms of probing for supporting evidence. And maybe the student comes back and says, well, I think it's status epilepticus because the patient, had a tonic-clonic seizure, and then, they're continuing to seize. They never had a seizure before, so I think apixaban is a problem because a head bleed would lead to this mental status change. And you're asking, like, why did you want to get labs? What additional information do you want? Well, I want to find out if the patient's been taking the apixaban. What medication did you recommend? I just figured we should load with an anti-epileptic drug to prevent further seizures. And valproic acid is an anti-epileptic drug. And you've asked, where did you get that recommendation? Why do you think that is? You're looking for evidence when you're, asking those leading questions. What's their clinical reasoning behind all of this? And they said, well, I looked it up on UpToDate and I remembered my class notes. Or you can ask, why do you think they didn't respond to the Ativan? So all good hypotheticals, great ideas. So the next step is to teach general rules. And this is where you kind of get to jump in and say some of those things that you were thinking about already, right? So now you can talk about, well, what is the definition of status epilepticus? What labs are actually important in a patient with kind of emergency, which is a seizure? Or, you can talk about the important vital signs and why they're important and why it's important to, protect their airway. You could talk about the ESET trial really briefly and choices of anti-epileptic drugs. But I would say again at this step, make sure to pick only, 1 or 2 points, or you may only have time to really point the learner to a few resources like, oh, read, such and such on status epilepticus, read the ESET trial. So I think that those are pretty good general rules that sort of lead us to, a lot of opportunities to teach from just this, really, really short encounter. And then say you wanted to reinforce what was done right. What are some things that you could say that are specific, that tell the learner the positive consequence of when they presented that? what would be a reinforcing thing to say? And I can kind of take it to the last step where they made some comments about what they thought was going on. Great job thinking about one of the treatable and med-related causes of seizure in the patient. Yes. Any other thoughts? Thank you for summarizing the treatment so far and thinking about the next step, anti-epileptic drugs in the treatment of seizures. So as far as reinforcing, I think you get the idea. You can say, I like that you prioritize a potentially deadly adverse medication reaction. You're thinking about medications as a pharmacist, or you included, a specific type of seizure and, how the patient was moving. It was a new onset tonic-clonic seizure, and you included the patient's response to the medications. Or, I like that you wanted to know the timing of apixaban to help determine a reversal agent. So you can usually find something really good, or, I like that um, you know, in this potentially emergent case, as one of the comments says, thank you for summarizing the treatment so far, and the next steps, as simple as that. And then make sure to include why you think it was beneficial, what's going to help. So, if it was about timing, that they took their apixaban for a reversal agent, asking this question will ensure that, we dose it and give it appropriately. Or you prioritize a more deadly thing like a head bleed that's going on with the patient. This will definitely ensure that we, get the most life-threatening things ruled out first, and help expedite patient care. So you're, thinking of those things first, um, including the positive effect that it had. And then the last one, how would you tactfully give modifying feedback to correct things that you wish they could have done better in their presentation and in their reasoning on this case? Somebody mentioned it's really great you're thinking about ICH here, but I want you to make sure to keep a broad differential and don't miss out on other treatable diagnoses. Good. So you noticed that, maybe there are more causes of a seizure and you wanted to give them modifying feedback because you noticed that the presentation was a little bit narrow about what was happening. So, I noticed you mentioned head lead as a cause, but there's, a few other things that I would keep on the differential, and you can go ahead and list those. So maybe going back to your step 3, right, and saying, here's a few general rules, like in somebody with a, acute mental status change like that, hypoglycemia could be a cause of seizure, and you can use that as a teaching point to go through, what differential is there. Um, This is hard because, yeah, it's a very specific case. Again, I don't want to get too hung up on the details clinically, but yeah, you can talk about different reasons for the patient and what happened to them. You can talk about basically not in the moment while the patient is having this emergency, but make sure to be specific about what they did or didn't do. Remembering to select the most appropriate references so they went to up to date. And then you're pointing them to the appropriate guidelines instead. So that's a great thought. And also include, again, what could happen at best and what could happen at worst, based on the potential error that they made. Well, at best, there's a delay to care because you didn't identify this, particular thing when you were discussing your reasoning. Or, at worst, if you use the incorrect guideline to, treat the disease state, or you went to Google to do it, at worst, you could make a wrong recommendation for the patient. So, including why, so they kind of remember, and then offering something to, address that as an alternative instead. Here's where to go to get more resources. So with that, I'm going to conclude, and now we're kind of at time too. Any final questions? Any other thoughts about this, or anyone who's used? I'll stop sharing here as well. Anyone who's used this technique, and how did it go? Anything at all?
Hey, Gina. Thanks so much for the great presentation. I am definitely a fan of this 1 minute preceptor sort of skill, and I've definitely tried to use it before. I think something I get hung up on sometimes is picking like focusing in, right, and not talking forever and ever. So it's definitely something I need to practice on. But yeah, really great presentation.
Thanks, Amanda. Yeah, that can be really tricky. We have to resist the urge to jump in and give those long, wordy lessons sometimes.
Gina, this is Bonnie. Thank you for the presentation. How do you, obviously you practice this, how long does it take you to go through this with a student or a resident? I mean, I feel like it's going to take me not 1 minute to do something like this. It's going to take me longer. I'm just curious.
Yeah, great question. Which is, I've honestly taken bits and pieces of it, where again, thank you for suffering through my emergency department example, by the way. But for situations like this, where maybe we have a lot of patients to see in the clinic, and maybe something's going on in the moment, or maybe the learner is getting it. I kind of abbreviate things, so that teaching a general rule turns into, go read this later, I'll send you the paper. And it turns into a debrief of a code, like let's circle back on this particular thing later, when we have more time, when it's less busy, or maybe I've just taken one aspect of it, like the patient comes, okay, what do you think is going on with the patient? I want you to think about it, and then we're just going to jump in and do the patient care. So, bits and pieces as needed. You really don't have to follow the whole structure. Take what works for you.
Okay, thank you.
Why?
Well, I want to give everybody enough time to have the dinner break, but feel free to email me, or talk afterwards, I guess, or come find me. Any questions or comments you have about this?
There was one comment I want to share before everyone goes off, was from the audience. I use a modified version. It depends on the learner and the case. On the short end, like 5 minutes of presentation up to 10. So it sounds like it can be condensed a little bit, as Gina is sort of referring to in her examples. Thanks so much, Gina. This is really wonderful. I always love hearing about the 1 minute preceptor and all of the different ways of applying it. I think it's a great technique, because we often have so much data in my practice area in the ICU. It's very hard for us to employ this too and be efficient in our teaching. So I think this is a really good tool to use, especially in the presence of overwhelming amounts of data, where you can sort of focus down and distill rather than just trying to brute force everything on your learners and expecting them to remember and retain anything. So thanks so much for that. So generally in the program, we have a little break now. So I can abbreviate that if everyone is in favor, and we can meet back maybe around 6:15 if that works for everyone. Okay, so I will plan to reconvene and start my portion of the night at 6:15. So thank you, everyone. And if you have any questions or anything in the meantime, feel free to throw it in the chat. I'll address it as I come back to my computer. All right, everyone. Well, I hope you had a nice brief break, and I am going to go ahead and jump into the second part of this presentation. I know that that was our quote unquote dinner break, but I just want to say I don't mind if you guys eat while I'm presenting this, so feel free to do so. I want this session to be relatively interactive. I have a few questions in here that I'll be using the Poll Everywhere software for, so you guys can feel free to use my link that's in the top left-hand corner on any device that you have, and just go to polleverywhere.com / Dexter Wimer 743 and feel free to use that to respond to these questions. Additionally, if you can't log on to Poll Everywhere via your device or don't have easy access to it, feel free to throw things in the chat. I'll try to keep an eye on that as well, so that I can answer any questions that might pop up there or address any comments that might pop up there. I want to say that this is an area that's still evolving much, and the pandemic was sort of a catalyst for this, as we'll talk about. But this is an area of interest to a lot of academic institutions now, UCSF included, and healthcare in general is sort of looking at all the things that we've been doing live and in person for years, and if there are things that we can change over to a more digital or telehealth setting. And so this topic will continue to evolve and will continue to be relevant for, I think, the foreseeable future, even if we're getting back to some sort of semblance of normal post-pandemic. That being said, this topic was selected many months ago when our learning environment was much less certain than it is now. So I apologize if a lot of these things have been ironed out on your service or a lot of these things have been discussed previously. But I think they're still relevant in case you might be designing a new learning experience or might be thinking about some of the different aspects that you want to refine with your general learning experience. So my objectives for this presentation are quite simple. I first want to identify some of the barriers that have been studied in the literature to digital learning. And then we're going to talk about concepts of synchronous versus asynchronous learning and what some of those examples look like, what are the benefits of each type of learning, and what are some of the downsides of each type. We'll also look at some tools and considerations for overcoming the 5 barriers that we're going to talk about to digital learning. And some of these tools are still developing, and some of them are areas that just need to be discussed with the key stakeholders in your learning environment rather than firm solutions themselves. We're going to review some of the solutions and some of the frameworks that have been set up in the literature from different disciplines, and finally study some of those examples that have been designed in light of the pandemic. First, I just wanted to take a step back and think about overall what the purpose of all of our precepting and all of our designing learning experience and all of that is. And it's really dependent upon which level of learner you're teaching. So if you're teaching students, your requirements basically come from the American College of Pharmacy Education, or ACPE, and they require that no less of 300 hours of IPPE or introductory pharmacy practice experience and 1440 hours of advanced pharmacy practice experience. And what you'll notice by that is that there's no requirement here of what that looks like, what those hours look like, what the design of and the makeup of those rotations look like. And so I think that's important and applicable to our digital setting. And then ASHP states that no more than 1/3 of a PGY1 pharmacy residency may deal with a specific patient disease state and population, and that residents must spend 2/3 or more of their program in direct patient care activities. There are some examples that ASHP has provided in light of the pandemic, and we'll talk about those later. But again, I want you to note here that it only specifies dealing with specific patient populations and diseases, as well as 2/3 in direct patient care activities. But there's no really stimulation of what the definition of direct patient care activities is. So that's sort of left up to interpretation of the reader for that. So that's going to bring us to our first question. And this is more of a general survey. So feel free to type in free responses, some struggles that you guys have had with digital and distance learning from a preceptor standpoint, or perhaps even from a learner standpoint, if you've had that opportunity to engage with your learners and have gotten some good feedback from them.
Dexter, I remember something that was a pretty big deal back in, like, I don't know, May of last year, was trying really hard to get students who were distance learning incorporated into ID rounds, but being really limited by the technology in the ID rounding room. And just, it's not always appropriate to stop everything that we're doing to try and set things up, for the learners. So struggling to incorporate them into the team was really, really challenging.
Totally. And along those lines, there's a comment about bad Wi-Fi. And so technology is definitely a big challenge. And we're going to talk about some of that a little bit. Other things that I'm seeing is motivation and student participation. Definitely, those are drivers of this. Zoom rounding for interdisciplinary communication challenges. You've got a lot of stakeholders in the room. You've got a lot of people sharing their opinions, their thoughts. It's hard to sort of figure out when it's your turn to talk, especially in this digital setting where you have sort of power dynamics at play. You have these normal sort of modifications of communication that we've designed for these round structures that are sort of overhauled by this digital setting. Unfamiliar technology to learn. Yeah, technology is going to play a lot into this. So I'm glad that you guys are bringing it up, and I'm glad that, I'm not glad that you struggled with it, but I'm glad that we're all acknowledging that it's a struggle still, and nobody is an expert at technology. From a didactic standpoint, limitations in active learning options. I love it. We're going to talk about that a little bit too. So I'm going to go ahead and move to the next question. And this question is, what tools have you used to aid learners or improve distance communication? So along the same lines, but this time we're more looking at solution orientation. So what have you done that has changed from some of those challenges early on and hopefully led to improvements? So we've got some responses coming in. We've got different orientation. Yeah, so a lot of orientation has changed around. Some other things that have changed is sort of intake of learners and how you evaluate how they're going to participate in the rotation. What modes of communication are you going to use, and sort of those things. We'll ask about that. Asking students to have their video on. Yes, I love it. I think sometimes we have to ask preceptors to have their video on as well. Additional technology tools and communicational tools, definitely. There have been a balloon of us learning about those and learning about how to keep our numbers anonymous and protect ourselves from inappropriate phone calls from our patients. Debriefing after rounds to compensate for broken communication. Yes, I think that's a wonderful acknowledgement to say that there are times where we just can't do what we used to do in these sessions, and making sure to take time to debrief, to talk about those things is really important. More pre-rounding and scheduled meetings, definitely. All those are components of things that we have done to change in this landscape. I think the scheduled meetings is particularly important, and we'll talk a little bit about that in a minute. So I wanted to share this quote before we jump into some of the meat of this presentation. And I want you to think about this sort of as we go through the entire presentation and sort of in your own learning experience development. This one came from a paper USC was working on for developing their digital curriculum. And it's really powerful. And I'll just read it. Taking an orally delivered lecture, recording it, and then converting it into a digital format is digitalization. The result is a digital representation. However, it is not a digital transformation. And I think what this paper really drove home for me was that overall, we can record lectures. We've been recording lectures for years, but we have this opportunity with the coronavirus pandemic to really change the way that we learn and really change the way that we precept, and hopefully take advantage of some of those things that the pandemic brought around and forced upon us to really transform the way that we teach, and hopefully either reach more students or make it a more convenient schedule for everyone involved in the long run. Short run, that might be a little bit challenging, and we'll talk about that, but I think it's a unique opportunity for us to really change the way that everyone learns. So let's talk about those barriers. So this comes from a study done in medical education, and most of the literature that will be presented today is from medical education rather than pharmacy education. The pharmacy literature around this is still developing, and a lot of it is very teaching setting specific. And so I wanted to avoid a lot of that very specific teaching setting sort of content and focus this more broadly so that you guys could walk away with some things to think about and some things to take back to your own settings for practice. The first one is time constraints, and then we'll talk a little bit about poor technical skills, which a lot of you brought up as things that are challenging for our learners and challenging for our preceptors as well. We'll talk a little bit about inadequate infrastructure and what that can mean, the absence of institutional strategies and support, especially early on in the pandemic when people were really reeling, trying to gain control of the clinical status of how we're going to take care of these patients, how we're going to protect our people, and all of those things were very high on the list rather than protecting our learners and protecting their learning opportunities. And then lastly, unfortunately, we'll talk about negative attitudes of all those involved and how sort of the stress and the pandemic, all of that has played into this barrier coming around. So talking about time constraints, all of you can appreciate that this is a very large component of our digital and distance learning barriers. And the reason this is multifold. We have time that we are supposed to be at work. We have time that we're supposed to be at home. We have our own personal goals. We have our responsibilities that we have at work. And all of these things play into our time. And unfortunately, because there's only 24 hours in a day and that number never changes, you can't gain more time just because you've gained more responsibilities. You might stay at work longer, but that's going to cut into your personal time. You might feel burnt out as a result and want more personal time, but that's going to cut into your work time. And so you can quickly get into this cycle where you are constrained by time and feel a little bit down as a result of that. And so contributions to this barrier are things that we just talked about. So lack of time or dedicated time, especially to these activities, is linked with increased burnout, especially among preceptors who don't feel as if they have dedicated project time to do all of this development and all of this setup for digital learning that's required. There's also the time investment for new material creation, and we'll talk about some strategies around these things as well. There's a lack of institutional incentives overall, so no additional time or overtime paid to develop these types of new curriculum or these types of new teaching instruments or new intake forms or anything to that effect. So overall, the general sense is that you need more time to do all these things, but there's not really enough time in the day and there's not really enough funds to support that. And finally, that comes back to the institution of not being able to support and engage the stakeholders. So how can we work along those time commitments and along those time constraints in order to overcome this barrier? So some things you can do initially is to think about a baseline assessment. So you can really set yourself up well to avoid a lot of these struggles, a lot of these time traps later on, especially around technology, with setting up a baseline assessment so that your learner and you are on the same page. And this goes back to pre-pandemic expectations, where we're really trying to set up what is your learner going to do on this rotation, on this experience. So what are the ultimate things that you want your learner to leave the rotation with, and what should they expect as a result? And then I think preparation, especially in these times, is really important. So some things that you can do is set up your learners with some pre-material, and we'll talk about what that pre-material might look like before coming onto your rotation, or have some dedicated time in the day where you can do your activities and your learner can work on some other activities so that you can work together, but work on separate things, and your learner doesn't feel as if you're not paying attention to them. Excuse me. And then lastly, figuring out how you assess for those requirements. So if your learner is expected to leave with certain knowledge, how are you going to evaluate that? And what are you going to do to make sure that your learner knows that you're evaluating that at that appropriate time? Especially in this setting where your learner is not directly observable, they're not there face to face many of the times. And so you sort of need to rely on more concrete examples and more concrete delineations of when your learner is doing things. So I want to stop there to ask a question before we jump into a little bit more content. And I'll ask, which of the following is an example of a synchronous learning experience? The first one is a time limited test. So you only have some time to do this test, but everybody is working on it at the same time. A recorded lecture, assigning a blog review on a hot clinical topic, and a small group discussion. Excellent. You guys all know what synchronous learning is. Everybody that has answered has said small group discussion. Now, I want to point out that a lot of these things could be made into synchronous learning, and a lot of activities can turn into synchronous learning from asynchronous learning. So a time-limited test is definitely an asynchronous learning experience. However, you could make it a group work test where everyone is working together to solve problems, and then maybe each group could present a piece of that problem. And so if you have multiple learners working, you can work to make this more of a synchronous learning experience rather than an asynchronous learning experience. A recorded lecture could be presented live, and that could be an example of a synchronous learning experience. And then assigning a blog topic on a hot clinical, blog review on a hot clinical topic. So you guys could look at different hot clinical topics and have them all presented together and learn as a group. And I think that that's an example of a synchronous learning activity from an asynchronous learning activity that's really good, especially in this time where everybody's in front of their computers all the time and everybody has access to anything that's out there in the evolving world of literature. So talking about the content types and really defining those, synchronous is really broken down as everyone learning at the same time. So it's an active, engaging experience, sort of like this lecture that we're delivering now. This lecture will be recorded, and so it will turn into an asynchronous activity following this. And so you can see how these sort of play into each other. There are benefits for both, and the benefits are the live learning for synchronous activities. So you can ask a question if you have a question, that question can be answered live and everyone can sort of learn from that experience. The downside for asynchronous from that aspect is if you have the question, you can't really ask it in live time. And so you might have to write that question down. You might have to email your professor. You might have to email whoever and figure out if you can get that question answered, or you might have to dig a little bit deeper into the resources yourself, which will cause a little bit more time. The other downside to synchronous learning, or an upside depending on how it's perceived by the learner or the preceptor, is the variability. And so if I'm delivering a live lecture, I might deliver it a little bit differently each time. And that may be beneficial to the learners, but it also may be confusing to the learners. And so if I present something one way for one session, a group of learners may understand it perfectly well. And then if I present that same thing in a slightly different way, that same group of learners may not understand the take-home messages as well the next time. The other downside to synchronous learning is that it is an exhaustible resource. And so you only have so many hours in the day. You can only present so many live lectures. You can only talk for so long. However, from asynchronous learning, everyone can do it at their own pace. And so students who have busy schedules, who have other commitments, who aren't able to necessarily adhere to the strict requirements of classroom learning or the strict requirements of commuting to an area to all take a class together, could then learn from this asynchronous pace. The issues here obviously are that people procrastinate, and so people may put this off until the last minute, and as such may not understand the material as well. The benefits are that it is durable and that it can last for a very long time without the need to be updated, a couple of years at least. And then it's also flexible and you can go back to it at any point. Some examples that we've talked about are live lectures, small group discussions, and journal clubs for synchronous learning. And then asynchronous learning, things that you're familiar with are recorded lectures, podcasts, and YouTube videos, and literature readings. So one concept that helps us maximize our efficiency when we're teaching, and this is something that is really beneficial, especially if you have a lot of learners on your service, is layered learning. And so something that I was interested in seeing as I was digging through the literature was things about asynchronous layered learning or synchronous layered learning, which we'll talk about on the next slide. So asynchronous layered learning is really interesting. And in this world where we're sort of able to record all of our conversations, including this lecture that's going on right now, you're able to give feedback on conversations that you may not have been there for. So for example, if your student is counseling a patient on their new anticoagulant, apixaban, you can have the student do that counseling over Zoom, have them record it with the patient's permission, and then you can listen back to it a little bit later and give them feedback on their conversation if you weren't necessarily able to be present for that. And this is a tool that we may or may not have exercised pre-pandemic, but something that is certainly beneficial and can serve as a lasting example even for other learners as well. And in line with that, you can listen in on conversations that you may not have pre-pandemic. So if your student is calling to run their X with the team, you could also have them record that conversation. And so you can listen back to it, and then you guys can discuss what could have gone better, what could have been done differently, what you might have suggested instead. And then you can use conversations for teaching. So all of those conversations can then be anonymized and used further for any teaching methods in the future, which is really nice and may not have been able to be employed as readily in the beginning. Synchronous layered learning is really nice too. And a lot of examples from the literature include things like standardized simulations. And so one institution developed some simulation cases that they would present to their residents, and then their residents would run through those simulation cases, work through them with the preceptor, and then they would in turn present the simulation cases then to students. And so I thought that was sort of akin to patient teaching points as well with layered learning, and thinking about the preceptor and the resident doing card flipping, running through patient recommendations, and then the resident could then do that with the student in perpetuity. And so this is really nice in the asynchronous world as well, because you could record those conversations and then listen back to them as the preceptor to make sure that your resident is hitting all the right points to the student. And then the really nice thing about synchronous learning is that traditionally we've thought of it as this top-down approach where it goes preceptor to resident to student. But there's a lot of talk, as you guys all are aware, about flipped classrooms these days, where the student then serves as the teacher. And so I think you could flip these roles as well in their head and do students presenting to residents and residents then presenting to the preceptor, talking about clinical teaching points. And so I think it's really good to not only encourage these preceptor skills for our own development, but to then turn around and encourage our residents and students to also develop this. And then one really interesting idea that came out of the literature when I was looking is clinical debate teams. And so this serves as both a synchronous and an asynchronous experience, where you can present an article or present a hot controversial topic where the students and residents can read through it, and then they can battle it out on a debate and persuade the preceptor one way or the other. And this is a really good synchronous learning experience where you can talk about the merits of certain literature presentations. For example, there may be a talk about Dexter versus Kcentra for the reversal of direct acting oral anticoagulant bleeding. And you may take one resident and have them team up with a student and work on the Dexter side of things, and have another resident and student team up and work on the side of the Kcentra things, and then present it to you. And at the end, you can talk about the merits and detriments of each argument and how they could be better phrased next time, and ultimately award a winner of that discussion. So with that, what sort of asynchronous materials do you guys already use in your rotations? I see completed discussions. YouTube, some slides, readings, topic discussions. Yeah, these are all sort of typical. I don't think a word cloud was the best representation for this, so I apologize for that. It looks like some of these things got a little jumbled up. But I think some of these are pretty typical examples and pretty good examples of things to use. Things that we can use now in this digital world that are available to all of our learners that I found really helpful are things like podcasts. And there are a surprising number of podcasts out there that are very pharmacy specific. And here's just a simple list of things that I'm familiar with. What I wanted to point out mostly from this slide is that you can see there are a large number of episodes for a lot of these. And so no matter what your practice setting is, you could find something in at least one of these that could be relevant and save you some time in this world of time constrained, stressful living. And so I think that by using this and supplanting it with your normal teaching, you can help with this. I also see a comment that the Society of ID Pharmacists has a podcast called Breakpoints. That's awesome. I always love learning about new podcasts. And like I said, you can always find good examples of things that you can supplement your learning with in these places as well. The other nice thing about them is sometimes they'll present something that's very controversial. And so using that also as a breakout of a discussion or of a clinical debate could also be reasonable as well and help out to not only drive home an overall teaching experience, but could also help reinforce the fact that we practice in a lot of gray areas, and oftentimes decision-making in clinical context is the most important thing. It's really hard to teach without a patient live. So it's really good to use this sort of as a way to frame that discussion. You'll notice that they all have a little bit different context depending on what you're doing, but many of them also include either reviews of guidelines or reviews of pathophysiological states, which can help reinforce your students' learning from previous. There are also many non-pharmacy medical podcasts that go over disease states, go over pathophysiology, and those are really helpful, especially since they will use language that the student or resident may not be familiar with in your practice area. And so here's just again, a simple list. And I would again point out that there are many, many episodes of these. And so you can likely find something that could be tailored to your learning experience pretty quickly here. Another asynchronous method that I think is really useful, especially in this time of digital and distance learning, is pointing out an AppLex chapter or pointing out a board certification material chapter. One that I like to use, especially when I'm precepting in the ED, is our colleague Zlatan Koralik's chapter on angioedema and anaphylaxis. It's really good to just after you see a patient, to have the learner just digest that material and work through that material themselves, and then think about what we did in that case and what could have been done differently. From a digital and distance standpoint, that's also really beneficial for the learner. If they are able to access the patient chart, you can say, hey, take a look at this patient. Here's what we did. Please read through that and see what you guys can come up with in terms of what you might have done differently. And I'm seeing in the chat that sometimes students watch relevant YouTube topic videos for select topics. And I totally agree with that. I think that's a really good tool as well. It also serves a lot of times for discussion, good points of discussion, because something might be said in these YouTube videos or in these pharmacy podcasts that seems like it's very clear, but sometimes it's not so clinically clear in real life practice. So I think that's a really good tool to use as well. And then lastly, board certification and continuing education materials. So continuing education materials, we have a lot of access to, and all of these are asynchronous and available and can be made available to our students. And I think that it's really helpful for them to see these things and to learn about these topics from these standpoints, especially in times when we might not be able to give them that one-on-one personal experience that we were pre-pandemic. Lastly, I'm sure that you all have this, but if not, I would encourage you all to create a central repository of these resources and sort of a how-to guide for your learners. Make sure that it's something that's available on-site as well as off-site, so not something like on the T drive for our UCSF colleagues where you can only access it on site, but maybe something like Microsoft Teams or Box, which is unfortunately retiring at UCSF, Google Drive, Blackboard, or something like OneDrive, which will replace Box. All of these things are really important, and it's also important to think about intra versus extra institutional access. So just thinking about equity and equality, all of the students that you get may not have access to all the UCSF resources. Ideally, they would, but you may have a student on your rotation that doesn't have that access, or that access is challenging to get. I'll give you an example. When I was rotating as a resident at the General, it was really hard to get access to their computer system. And so there were portions of their computer system I just didn't have access to at all. And that would translate poorly to this digital and distance learning area where I don't have access to a computer system that I need to look at from offsite. And so I think that thinking about those things and making sure to set your learner up for success is really important in this digital world. That transitions us nicely into the next topic, which is technical skills. And so technical skills is one that obviously a lot of us have illustrated as a problem in this digital and distance world, where we're talking about using new technology, using new apps, new software that we're very unfamiliar with, that we haven't had a lot of practice with, not only for us, but also for our learners. And so we're going to talk about some of the strategies and some of the considerations around those things. So first, just like in the other topics, we want to think about what technology does our learner really need to utilize for this rotation. And so setting them up with access for those things ahead of time, making sure the learner really understands how to use that technology and can use it in the same way that you can use it. And I think one of the things that is really helpful in these situations is just to model for the student and walk them through, like, here's what we're going to do on a day-to-day basis. Here's how you would do those things. One of the really great tools about Zoom and some of the other video clients is that you can share your screen with them and just show them exactly what you're walking through to do these things. And so I think that's a really good application of these softwares to use as well, if you aren't already using that. And then thinking about backup plans. So as we heard, Wi-Fi, bad connection, bad servers, those types of things pop up, and there's nothing we can do about them. But I think the important thing is to have some sort of backup plan. One of the examples was when we were interviewing candidates for residency. We wanted to make sure that we knew how to reach the candidate, since we have a very tight schedule, and we wanted to make sure to keep on that schedule and not leave the candidate at a disadvantage. We provided they all provided us with their phone numbers and a way to reach them in the event that their Wi-Fi froze, in the event that their video capture stopped working. We would troubleshoot those things. And so we had an algorithm ready for these instances where we might have difficulties with the interviewee. And so I would encourage you to do that as well for your rotation, and think about, like, if Zoom fails, what will we do? If they have bad connection, what will we do? If I get cut off or called away to an emergency meeting or to an emergency in the hospital, sort of what will I do to help triage that? On the opposite end of that, what contact information should the learner have? So if something happens and the learner is unable to reach the preceptor, is there somebody else that they should be contacting to make sure everything is okay? And then lastly, thinking about where the preceptor is working from. And so I'll use myself as an example here. I'm working from my home currently, and I have a little puppy who's rambunctious. And so thinking about that environment when you're teaching a learner and when you're doing those things is really an important consideration. You don't want this puppy barking in the background and disturbing away from your learner. You don't want outside noise going. You don't want the background behind you to distract. And so I see many of us use digital backgrounds. Unfortunately, because of the limitations of my technology, my computer's too old to do that. And so it won't actually allow me to have a digital background. So as you noticed, I positioned myself against a wall where there isn't any motion in the background. There's not a lot of distractions. And so these are all things that you want to think about when you're creating this environment for your learner, to minimize the distractions and minimize the abilities of failure and really maximize your teaching. Considerations for this is make sure to model appropriate video etiquette. So if you want your students to have their video on, make sure that you always have your video on. And if you don't have your video on, make sure to clearly communicate why that is. And then same thing for talking versus having a conversation. I think a lot of times we are not in tune to the background noise that may be happening. And so oftentimes there may be some sound that's going on in the background that's really distracting to your learner that you may not be aware of because you've been working in that environment for a long time. So I think it's really important that when your student is talking or when anyone is talking, make sure to mute yourself so that you're not creating that distraction and making that student feel as if they're not as important. One of the really great things about having young learners and technologically adept learners in this world is that they know a lot of the tools that we may not be aware of. And so I think one of the really great things you can do on intake for these students to boost your own technological skills is to have your learners teach you about technology and teach you about the tools that they've used in other rotations. And so if you're taking in a learner and they've used some other form of technology for their digital and distance learning previously, have them teach you about it. It can boost the students' confidence. It can really show them that they're able to teach something and that they know something that their preceptor doesn't, which is a rare experience occasionally. And also it's a shared experience for both of you to really learn and to work as a two-way street. I think that's really helpful. The learners can also sort of help develop your expectations for these settings. So they can talk about what was very difficult for them transitioning into your experience, what they thought could have gone better. Oftentimes this is really hard feedback to elicit from your learners, but I think really pressing them and saying, you know, you can help make this better for future students because we're all learning together, and really acknowledging that this is an evolving field and that all of our expectations are still changing for these. And then offering shared testing and design. So saying like, hey, I implemented your changes. Can you go through it and see what you would keep, what you would not keep? If I can do it any differently, let me know. And I think that's really helpful to know that you have good input from your learners. And it's also helpful for the learner to know that you're open to that feedback and that you're constantly evolving and incorporating feedback from learners. So I briefly want to talk about different methods of recording. And so in terms of capturing asynchronous material, I really found two very beneficial ways to do it. And I'm sure there are more out there, but I think these are the top two that I use when I'm recording things. So recording in Zoom is really helpful. It helps you to live capture meetings. It helps you to screen share for processes. So things like order verification that students may not get to see because they're offsite now. You can screen share, you can walk your students through different nuances of complicated orders. And the nice thing about that is you can record it. And so you can record it so that you can show the student those processes, and then that process is available for future students where you don't have to go through that exact example because they may not see that exact example in their rotation again. And so having this repository built up of different recordings of complicated orders or different nuances of orders could be really great for student learning. It's also helpful walking through things like order sets or complicated treatment algorithms that you can walk through with the learner that's specific to your site. The downside is, unfortunately, the recording is only available after the call ends. So Zoom won't give you that recording until you're done. That could be good, that could be bad, depending on what you're doing. The nice thing is you can pause the recording. So during our break for lunch, I paused it so that the recording is still one long recording, and after all this can be uploaded. The downside to that is that the recordings can be quite long as a result. On the opposite end, recording in PowerPoint is super helpful too. So you can do more segmented recording, and you can record per slide, or you can record per different sections of the recording. It's also really easy in PowerPoint to re-record. So if you mess up on a certain section, you can just delete that section and go back and re-record it very easily. On Zoom, it's much more challenging since you would have to stop the recording and re-record a whole new time. Just going into how to record on Zoom. So the record button, fairly easy, and then pausing and stopping. The one thing that has been added recently that I have not had the opportunity to test out, but I have heard good feedback from others, is the live transcript option. I think this could be very helpful for our students learning who have different learning styles, different learning abilities, is to have this transcript option available. And it can be available and applied to the recording as well. Recording in PowerPoint is fairly similar. I just wanted to highlight this in case you all aren't familiar with it. Going to slideshow, clicking record slideshow, and then you can pause it, you can stop it, you can move it forward to the next slide. And then you'll see that once the recording is made, it gets applied to the bottom right hand of your slide, and you can click play on any of those slides. I see comments that we always rely on residents for amazing tech ideas, and I totally agree. I think the residents and students are very in tune with their learning and very in tune with the technology. So they're great resources for all of these things. So inadequate infrastructure, this can mean a lot of things. So when I think about inadequate infrastructure, and what I saw in the literature is that this could mean, number one, that our rotations aren't set up for this type of learning, and that's certainly true. It can also mean that we don't have the technology available, that we don't have the ability to scale up to this level of learning from a digital standpoint for all of our learnings. And it could also mean that we don't have the funds for those types of digital interfaces, or that we don't have the ability to allow students to access patient information offsite. And all of those things are certainly legitimate problems. And so I wanted to talk through a couple acknowledgements on those and how to sort of acknowledge those problems. So number one, again, just setting up the learning environment. So making sure that we have infrastructure and we have a design to our learning experience can really help skirt around this problem for our learners. So setting up that expectation of what time will we meet and how often will we meet. So are you going to meet it 2 times a day? Are you going to meet before rounds? Are you going to meet after rounds? Are you going to meet 5 minutes before every patient visit? How are you going to structure that? And then what platform are you going to use? And as we talked about before, thinking about extenuating circumstances. So what if your Zoom crashes? What if your internet is not working? Thinking about that diagram to develop that infrastructure for your own rotation and for your own benefit for your learners. Making sure to also be sensitive to socioeconomic limitations. Learners may not be able to afford really great technology. You know, they're students, they don't have a lot of money anyway. They've taken out enough loans to bury them for the rest of their life. They don't have a lot of these abilities to access really nice, clear communications. And so sometimes they might have sort of staticky or sort of broken communications with you. And I think being really sensitive to that and understanding that as an issue may be reasonable. And I think it's okay to bring it up to the learners and say, hey, like, I'm having a little bit of trouble from this understanding. Is there a different method that we could explore? Or is there something that we can think about to make this better and more communicative for both of us? And I think acknowledging that and talking about it together with the learner is the most important step during that. And lastly, just being very clear on your instructions and expectations as always. So I told you that ASHP had some examples of some activities that can help you set up your infrastructure or help you set up this learning experience at your own site. So the ASHP example activities of things that can be done during the pandemic, or things that help satisfy requirements for learners, are comprehensive medication review. And these things can be done via phone call, via video call, or via acquisition of documents. And so what that really means for our learners is that they can actively interface with the patient and actively review all of their information. Or if you have a setting like where I have, where the patient is in the ICU and may be intubated or sedated, they could acquire documents from the patient's outpatient pharmacy and could facilitate making that phone call. Again, these could be, with permission, recorded or destroyed, if not with permission, afterwards for teaching purposes. And so I think it's reasonable to think about those things as a teaching activity as well. Drug therapy and disease state management. So this can be taught really via a specific patient, but without patient-specific identifying information. And so if learners don't have access to patient charts offsite for whatever reason, then this could be something where you can send sort of some information or screen captures from the patient's chart with unidentified, like after they have been de-identified, so that the learner can really engage in the patient case and really understand how medications work on a patient specific level. And then a lot of these other things are things that we have talked about previously, so I won't dwell on them too much. But I think one of the things is that came out of this and came out of some of the literature is talking about role playing and really walking the resident or student through what you do on a given day. And so I think that's really helpful from a video standpoint if you can record that and you can show your learners exactly like, this is what it looks like for a day in the life of a ICU clinical pharmacist. Because if they are offsite, if they are not able to directly observe you, they may not know what that looks like. And so I think helping them understand that and helping them see a little bit better can help them make their decisions in the future about what they might want to do, as well as inform them about what you do on a given day. Other pharmacist-driven distance activities that can be done with minimal technology are adjusting medications therapies. So things like providing a patient with providing a patient profile to a learner and saying, what would you change? Or what medications do you think can be optimized? And things like that are really good skills that they might learn in a clinic that you could then teach them from a distance standpoint without having to have the patient or having the student on site. Other things like self-monitoring devices and laboratory monitoring, so adjusting glucose, adjusting INR, adjusting insulin in response to glucose, or adjusting warfarin in response to INR could be very helpful for these patients. And it's definitely something that can be done distance and has been done distance for a long time in a lot of settings. Providing education is another really good one that pharmacists can do from a distance setting. So you can have your residents or your students develop materials that could be served as education to your providers, to your nurses, to other health disciplines that can really aid in their learning, as well as in the departmental goals of pharmacy all over. So areas of improvement, I think this is really important to think about from an infrastructure standpoint and thinking about overall development of a better setting for everyone. And one of the drivers of this from the literature is about collaboration and communication. So not working in a silo, not saying that my rotation is unique, I can't possibly learn from other people, or, I think that teaching in the ICU is different from teaching in any other setting. So there's no way that I could learn from other disciplines. That's really detrimental to the overall goal of learning, is what is seen in the literature. And the most successful programs, the most successful digitization and the digital transformation of these programs is really seen when everybody talks and shares common goals of learning for these patients. Crowdsourcing creation of new materials, so working together and not just trying to develop it again all on your own. It's a lot of work to try and develop these materials, and many people are going to be doing the same things. And so trying to work together to say, how can we use this other resource to apply it to a new setting, or thinking about those types of activities. And then lobbying for departmental resources. So we talk in the beginning about not having enough time. If you don't think that there's enough time, put together a proposal and think about, like, if we had resources, if we had X amount of time, here's what we would do with it. And I think that can lend to a lot of different learning opportunities for everyone, and different good opportunities to collaborate, as well as develop a better, more transformative experience for our learners. And lastly, involving other disciplines. So we are not the only discipline as pharmacy who is digital and distanced. And so thinking about other disciplines like nursing students or medical students and working together in a team setting to educate everybody together is something that the pandemic could force us all to do a little bit better. This one sort of plays into the last one of infrastructure, but thinking about institutional guidance and thinking about site-specific guidelines. And so the question from this is, has your site formed a group to discuss how to best teach learners in this environment? I was really hoping there'd be a yes in here, but unfortunately it looks that we're all still pretty siloed in this. And I think that that's not unexpected for this setting. I think it's really good at this opportunity, especially where we're all starting to feel a little bit better about things. The acuity of coronavirus patients has gone down. The spread is really well controlled in San Francisco. And I think thinking about now, all of the lessons that we've learned from this and how we can best transform our teaching going forward, this is a really good time to do that. And so I would encourage you to talk with the other groups at your site, talk about within your pods, or talk about within your departments about how can we change our curriculum? What lessons did we learn that will benefit learners in the future? So there are some guidelines along how to do this, and ACCP has an entire position paper written about this that was published in the middle of last year. And so it's very generic from this representation, but here's the central figure from it that has a framework. And essentially what it does is breaks it down into a couple different aspects. And so the first aspect they say is usable interventions or innovations. So thinking about things that will actually be used and things that can actually contribute to patient and learner outcomes as well. And then thinking about stages. So breaking those innovations, the ultimate goals, down into a couple bite-sized chunks and thinking about how to do each of those. And then drivers. Drivers is really important and was really focused as one of the main bodies of this paper, where it talks about getting buy-in from the organization, getting buy-in from other stakeholders, getting buy-in from the department, and thinking about having a leader for each of those stages and having a leader for each of those driving innovations to make sure that you really are able to spearhead this and collaborate together. And then working in cycles. So once you have that driver, once you make that stage, making sure to evaluate continuously of what's working, what's not working, what can we change, and then making sure that everyone holds each other accountable for those changes and holds each other accountable for those pieces is what AACCP recommends for the implementation of these types of learning environments. And so in that, they actually focused on a couple tenets for the ability to do this. And this is an entire figure in that paper. So I would encourage all of you to refer to it if you're looking for more specifics. But the indicators that they adopted were 8 long. And so thinking about acceptability, adoption, appropriateness, feasibility, fidelity, penetration, sustainability, and of course, cost. And the definitions that they used for those things are listed here. But essentially what they recommended was thinking about all of this framework before actually starting to work on these tenets. And so really thinking about the proposal again to the department to say, like, here's what we want to do. Here is how we think this could benefit all of our learners. Here are our next steps. How can we make this happen is really what ACCP encourages, is coming up with a stepwise approach to move through these transformative experiences in our learning. And then thinking about things that you can institute that would really have institutional benefit as well and help develop that infrastructure. So having students who are distanced, they can work as a drug information service, and that would benefit them tremendously. This was developed in one of the papers talking about an activity for students to have a unique learning experience where they would just take drug information calls from whoever across a health enterprise. And that could be an entire experience for that patient or for that learner that wasn't otherwise available. And then things that we all needed a lot throughout this experience were things like vaccine reaction information and messaging. So thinking about having students really dive into the reportings, dive into the literature, and really evaluate these things about what are these reactions that patients are experiencing and how clinically relevant are they? And then thinking about the drugs that we use. So coming up with tip sheets of what to use, what not to use, what are the guideline recommendations, really using our student armies to sort of think about these things and help develop those really literature dissection skills that students really need to have in order to be successful clinicians, and that inquisitiveness that they'll need can really be developed. And these all can contribute dramatically to the institution as well. And then things that are specific to are not specific to UCSF, but are things that we use students for while they were on our rotations, were things about code card care for COVID codes. So if we have a COVID patient who codes, what do we do with that code card? How do we process it? And then patient-owned meds as well around COVID and coming up with those policies. It's a really great experience for students, and they don't have to be on site to do these policy developments, to think about things that they want to institute. Last, but certainly not least, is how do we deal with the negative attitudes around coronavirus and digital and distance learning? So one of the things that comes out of this is that we are all probably experiencing some level of burnout and some level of exhaustion due to the mental anguish, the social anguish around the coronavirus, around the last year and a half of all of this disastrous things that are happening around us. And so I think we can appreciate that there's going to be a little bit of negativity around all of that just from that. And then asking everyone to completely change the way that they learn and the way that they deliver content not only multiplies that, but it sets us up for a really nasty sort of interaction. And so exploring that a little bit more, we can look at positives and negatives. And this is certainly a simplification of a lot of the things around digital and distance learning. But from the perception of a preceptor, the positives are that you don't have to make any more room reservations because there's no more rooms. And so trying to find space around UCSF is always really challenging. And so this is something that we don't have to deal with anymore. Recording and reusing distance learning, as we've talked about, along with screen share and capture. So you can use a lot of these things over for multiple purposes, and then easily integrating other learners and preceptors. Before, it was hard to get a lot of people in one place, especially in my learning area, where trying to get a bunch of ICU practitioners in one room is very, very challenging when you have very sick patients who need your attention. And so this is really easy where people can just zoom in and participate from that aspect without having to physically be there. It's also really helpful for the learner perspective, because if things more emergent happen, they're aware of it much quicker and can respond much quicker alongside of the preceptor, rather than having that delay of communicating to the student, then having the student show up and all of those things. So it's much better from that standpoint. The negatives, obviously, as we know, technical challenges. Hands-on learning is super limited. So things like having good code experience, having good hands-on medication compounding experience, those types of things you don't really get to show your learners as much. And then having two learning environments. So if you're working in a hybrid model of digital as well as in-person learning, it's really challenging to orient one way or the other from day to day. From a learner perspective, the positives is that they're still able to learn. So we didn't abandon them totally in this digital world and say, well, we can't teach you because we have to go deal with this pandemic. So it was really nice that we were able to sort of pivot on that. It's also nice that they have more one-on-one time. I think this is something that we as preceptors sometimes don't fully appreciate, that at least in my practice, we don't have that sit down discussion time with learners every day sometimes because of medical emergencies and whatnot. But with this, we don't have to coordinate a time for the student or resident to find us, to sit down, to discuss all those things. We can just do it on Zoom. And if we get interrupted, we could just Zoom back afterwards. And so having those things and having that efficiency built in is really helpful. Some of the negatives are, as we mentioned, in-home distractions or distractions with technology, the detriment of no hands-on learning, and then direct patient care being really limited. So really being able to lay eyes on the patient to really understand pathophysiologically what's happening inside as well as outside. And then the colleague interaction and collaboration is really a really huge detriment that we're going to have to figure out how to cope with coming out of this with their next generation of practitioners. And so being able to give those recommendations in a large group setting and being able to have that banter back and forth with your colleagues about what the correct decision for the patient is going to be really challenging to interact with going forward. So with all of that, what evidence do we have that students are enjoying or not enjoying these remote rotations? And so it actually looks from this survey that was conducted among APP rotation students. You can tell the number is fairly small at 48, but this was one of the more robust surveys that I could find, where they were talking about positives of their remote experience. So things that they thought contributed to good learning, and these numbers are all greater than 50. So at 81%, good communication with preceptor and set meeting times. So as we mentioned, just making sure to communicate your goals and expectations, and making sure to denote when you want to meet, how often you want to meet, and how you're going to meet, I think is really important. And then having that routine set up daily is really important to learners. Things that they didn't like are the opposites of those. So lack of set work hours, lack of a daily routine, and mismatched perceptions between the preceptor and the learner. So those are things to avoid, as we've talked about before. Some of the comments from the survey, and these are from a preceptor standpoint, is if you ask me to peer review something that I have no expertise in, I'm reluctant to do that. And this was sort of in reference to talking about the technology and using all of the technology to teach learners. And this speaks to our discomfort overall. And I would encourage all of you to think about flipping the script in these situations where you may not have expertise in that, but actually your learner may have a little bit more expertise in the technology than you do. And so using them to help gain that expertise and help gain that tool could be really helpful. Educators noted feeling overwhelmed with the entire process of engaging with new tools. I think we can all appreciate that. And then creation of new content often led to frustration. So really looping in your collaborators and looping in your department to help you in that aspect, I think is super helpful. On that note, collaboration, just remembering that we're all learning and adjusting together and trying to come together and figure out what is best in this brave new world, and trying to figure out what we really want to do with our learners and how we want to do that. So in the last 2 minutes, what I would like to do is just run through a couple of examples from the literature. And this is from optometrists and their education offsite. And so really what they did was they set up this whole session where they would meet with a student and provide a case outline. The student would then conduct a presentation with the educator, and the educator would run through recommendations and assessments as well. After that, the student was to record a 90-second education video. And then that education video was reviewed by the facilitator, by the evaluator. And then they would give feedback based on that video about things that went well, things that didn't go well. And then the students would re-record that video after the feedback. And so I think this is a really good process of something that is both synchronous and asynchronous, where you have some meeting events where you're talking, giving live feedback, and then you're reviewing how the student integrates that feedback and how they respond to that feedback on the opposite end. So I think this is a really good setup overall. And then this one is a generic example from a pharmacy school where they just sort of talked about generically looking at telemedicine and improvements opportunities as well. And so I think this one is a lot less specific compared to the previous example, but could be used to help set up a good framework for interacting both direct and non-direct patient care activities. I want to make you all aware of some pitfalls as we move forward for this, and making sure that we all keep a good vision about what we want to do with our learners and how we really want them to engage with their learning environments. So thinking about improving upon how our learners learn and how we deliver that content, rather than overall efficiency and experience, I think is most important. Make sure not to include too many subject matter experts, as the various opinions can just sort of swirl around and not really reach any end. And that's what's documented in the literature as well. So making sure not to have too many cooks in the kitchen, but just enough so that you have a good collaborating group. And that's a hard balance to find, and something that is dependent upon the process, but something to make sure not to make the group too big initially when you're developing these processes. Making sure that you have a linear process, so thinking about a beginning and an end for development of content, but then after that, making sure to reassess that process as you go through. So having a clear vision of what you want to accomplish, and then being patient with that. These changes take a lot of time, everyone's under a lot of stress, and everyone sort of is at different levels of readiness to make this transformation. So these things may take time from that standpoint, and institutionally changes usually take a lot of time to make anyway. So thinking about all those things and being cognizant of it. I wanted to ask what everyone's next steps were, but I'll just skip right over that to the end and take any questions if you guys have any questions or any concerns or comments or anything from the presentation. Thank you all for your attention.